Welcome to the third meeting of the COVID-19 committee. We have only one item on our agenda today, and that will be two separate evidence sessions with individual witnesses. And we're looking specifically at the issue of lockdown and the potential arrangements for relaxing the current restrictions. For our first session, I'm very pleased to welcome Sir Harry Burns, Professor of Global Public Health at the University of Strathclyde and formerly Chief Medical Officer for Scotland from 2005 to 2014. Can I welcome Sir Harry to the meeting, and can I invite you, Sir Harry, if you wish, to make a short opening statement?
Yes, my experience as Chief Medical Officer at the time of the swine flu pandemic, the H1N1 virus, taught me that these pandemics are complex systems where lots of different interests come together, and managing such complexity is hugely difficult. The critical thing is to learn from the process, not to blame people for doing things that you don't think were right and so on. Just share ideas, learn what works and apply it. So in terms of our present state with coronavirus, there's a fair amount of finger pointing going on all over the system, which I don't think is helpful. At this stage, we should be focusing on trying to understand what we can do to manage our way out of this, to get economic recovery, social recovery, and do it in a way that limits almost to zero any further damage that this virus can do. So a very positive approach to thinking our way out of this is what I'm interested in.
Okay, so Harry, thank you for that introductory statement. If we can move on to questions, I wonder if I could just start with two very general questions. And firstly, if I can ask you about the approach outlined by the Scottish Government to pursue a policy of test, trace and isolate. And I wonder if I can ask you what you think of that approach in general terms, and also what benchmarks do you think need to be met in terms of that policy before we can start relaxing some of the current restrictions that we have in lockdown?
Yeah, so the lockdown policy that we have just now is essentially test, trace and isolate without the testing and tracing. It's isolating and it is working. If we are going to move in a way that lifts lockdown and allows people to begin to go about their business, their social, meet their social needs and so on, then we need to know who is infected and who is at risk of spreading the virus to other people. So there's been a huge emphasis on testing. There's been, people have set goals, we will test 100,000 people a day, blah, 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 and so on. That's all very well, as long as you know that the testing is accurate and know what you're going to do to trace. There's no point in testing unless you're tracing the contacts, because that's the step you need in order to then go ahead and isolate them. So what I'm hearing some slightly worrying things about the testing process. I'm hearing that, a nurse has shared with me the fact that she was feeling unwell. She went with her family to one of these drive-in places where the car window was opened, the person running it put in 4 testing kits, and the nurse, her husband and her 2 children were told to swab their own throats. Well, if any of you have ever tried to swab your throat or stick a swab up your nose or whatever, I'm not sure that I would trust a 14-year-old to do it properly. So the quality control around this kind of thing, I'm not sure that it's there. The other thing is that the fact that there's so much emphasis on the number of people being tested a day suggests that, just get through as many as you can, never mind the quality, feel the width, as it were. So we need to be sure that the testing that is done is accurate and is giving you the appropriate information, and then there is the appropriate follow-up. So the tracing app that's being piloted, I think, is an important thing, although from what I'm hearing in Singapore, only about 20% of people downloaded it. We've got to encourage more than that to do it here. But we need also to have people out there who are prepared to go and trace contacts, because then you isolate them, and what you've got is a more focused form of lockdown. So it's that process of not just focusing on the testing, focus on the contact tracing, and make sure you have people who can give the appropriate advice to ensure that folk isolate for the 14 days that might be necessary if they are positive. So we've got a long way to go on test, trace and isolate, I think, at this time.
Okay, thank you for that answer. And I'm sure some of my colleagues will want to come in and probe a little bit further on some of the issues you've just touched on. But can I ask a second question again, just to start framing the debate? The discussion around lifting lockdown is sometimes framed as a choice between saving lives on the one hand and saving jobs on the other. So it's a choice between saving lives and the economy and money. And I wonder if you would agree that that misses some of the key issues here, particularly around public health more generally. What we know is that there's been a 70% drop in the number of cancer referrals from GP to hospital. We've seen routine cancer tests being postponed. We've seen a major decline in the number of people being admitted to hospital for coronary heart disease. We're also, of course, I expect, going to see a very large increase in concerns over mental health due to the current isolation. Is there a risk that the current focus on diverting all NHS resources towards COVID-19 patients, which is entirely understandable, but is there a risk that we are ignoring the more general health of the population, both physical and mental, and we're not paying enough regard to that issue when it comes to considering extending lockdown?
I think you're right. There has been some unintended consequences of lockdown. At one point during March, we were seeing, and this was a discussion I was having with public health colleagues, the number of deaths that we were seeing in Scotland seemed to be that were non-COVID related or apparently non-COVID related, because some of them would have been undiagnosed COVID, I think. But it seemed as if the number of deaths per week we were seeing in Scotland was potentially 200 or 300 more than you would have normally seen in the same weeks in previous years. And that may well have been people sitting at home with conditions that needed urgent attention, but they were too frightened to go into hospital. So the message, this very strong message of protect the NHS, I think, may have had these unintended consequences. There's no question that the anticipation of overwhelming intensive care was a very real one. I know that from discussion with intensive care colleagues. But we needed to maintain primary care and support primary care in a way that allowed people to feel they were able to go and see their GPs and be referred to non-COVID parts of hospitals that were still functioning. So yes, there were physical health consequences of lockdown and clearly mental health consequences. The whole issues of domestic disharmony and violence and so on, I think will have proved to be very real mental health problems, particularly amongst young people. The anxieties of young people who don't get to sit their exams and so on, all of these things are damaging well-being in society. So we need a clever, thought-through process of transition. And I don't think that is suddenly releasing lockdown so that, we see packed trains and all this kind of thing. We need to think about what works, why what works consistently, in order to phase our way out of it.
Okay, thank you very much for that answer. And again, I'm sure some of my colleagues will want to come in and probe some of these issues in more detail in a moment. Okay, next questioner is the Deputy Convener, Monica Lennon, please.
Good morning, thank you, convener. Good morning, Sir Harry. We're here to take evidence on the best way forward and the preparations that need to be taken as we ease lockdown. And you said in your opening remarks that this is very complex, and it's important that we apply learning as we go. Fully agree with that. So can I ask, in your view, before we make decisions for the next phase, what do you think could be done better at a UK level and at a Scottish level? And on testing, I was going to ask about capacity, but you've broadened that out by saying it's not just about the number of tests, but also the quality. That example you gave about the nurse and her family, I think, is a really important one. So what would your advice be to the Scottish Government to ensure that we have the right volume of testing, but also that the quality and the accuracy is reliable? Thank you.
That second question is difficult, because if you get a test and it appears to be negative, you don't know, unless you've had someone who knows how to do the testing actually doing it. You don't know if it's negative because it's been done properly or not. So I would say that we need to impress upon the people doing the testing that there is a way to do this and do it properly. The other thing is that there are tests in development that will focus on saliva. So it may be that you, instead of swabbing throats and so on, you spit into a test tube, and that's pretty easy to do. So it may be that it's appropriate to move into different forms of testing. But the critical thing is to test those who are capable of spreading. Again, I hear stories of people going to these hubs, these primary care hubs that deal with folk who are suspected of having COVID, and these people being told, yeah, you've probably got it, just go home and stay in for 2 weeks. And they go home to a home where they have young people and, old people and all this kind of thing, and they've not been tested. So, so there is an inconsistency across the place. And, some of these examples are not Scottish examples, they're stories that I'm hearing from down south. But there's an inconsistency here, so we need to have a protocol in place that sees people suspected of having it all being tested properly, not just being told to self-isolate. That's particularly true of care homes, I think, and the people going into care homes who may have a cough or a subtle change in their sense of smell or whatever that would point you in the direction of COVID, and they're capable of spreading it. So we need that to happen. And we need also a process for tracking their contacts. I think the app is a clever idea, but it depends on the number of people who are prepared to download it. I would have no hesitation in downloading it from my point of view. The other thing that we haven't mentioned is mask wearing. Now there is, I think, muddled thinking about masks. I've heard it said, the evidence on masks is not very strong. Well, that's not true. The evidence that if you wear a mask and you're negative, that it protects you, the effect of that is relatively slight. But if you are a carrier and you are capable of spreading it, and if you wear a mask, the evidence that will reduce the spread is very significant. A colleague in Spain has sent me a poster they use over there, which basically shows two people having a conversation. It's a cartoon of two people having a conversation side by side. One is COVID positive, the other isn't. If neither of them are wearing the masks and they're talking for 5 minutes, the person who's negative has a 90% chance of getting COVID. If the person who is positive is wearing a mask, the person who's negative has a 70% chance the person who is negative has a 10% chance of becoming positive. So the idea that wearing a mask will protect you getting it, the evidence for that is not strong. But if you've got it and you wear a mask, then your chances of spreading it are very much less. So we should be encouraging mask wearing when lockdown occurs. Particularly, First Minister is absolutely correct on public transport and in supermarkets and shops and so on. Wearing a mask is important. So what we learned from things like the improvement collaboratives on safety in hospitals and so on was if you do lots of things that have a small effect and you do them all consistently, they add up to having a significant effect on outcome. So things like wearing a mask and having consistent testing and being prepared to isolate the people who are positive, all of that will have a significant effect, hopefully as great as present lockdown. So moving out of lockdown would then become safe. I am in contact with a big network of people across Europe, particularly in Germany and Austria and Switzerland and so on, that have had some success in managing this. My German colleagues say, yeah, you all think we've done really well, but actually we don't think we've done nearly as well as we're getting credit for. But, so I've asked them the question, what did you do that you think worked, that we could do, that would do it and do it consistently, that would help us move out of lockdown? So it's that kind of shared learning that we need to have. We need to have the mental attitude of let's learn our way out of this rather than argue our way out of this. Arguing and finger pointing does no one any good. Let's share good ideas and let's move consistently out of it.
Thank you. I wish I had time for lots more questions, but I think I'm only allowed one at this point. So maybe move on to an issue that's given me a lot of concern, and that's around our care sector, care homes in particular. And it's clear that the preparations for care homes were lacking, and without dwelling on that too much, in your view, Sir Harry, what can be done now and in the days and weeks ahead to protect vulnerable residents in care homes? What measures can be put in place that are not already in place? And you mentioned about symptoms. You gave an example about a care home. It could be that there's a change in sense of smell or taste. Now, previously, we've heard from our advisors in Scotland and in the UK that the main symptoms to look out for are around cough and fever. And early on, people were asking about subtle changes like sense of smell and taste. And the National Clinical Director, Jason Leach, had said these were not things to worry about. Has that learning changed? And is there a difference perhaps with older people in terms of symptoms?
Yes. So my comments around care homes are exactly the same as I've said before. Test people who are going in. Make sure that those that are positive are not going in, and do that consistently. If you get tested today and you're negative, well, in a couple of days' time it might be positive and so on, and therefore you're looking out for subtle symptoms. And yes, my a colleague of mine who's an intensive care doctor developed COVID. And the first thing he noticed was absence of a sense of smell. So he went into his kitchen and couldn't smell the cooking, and he realized, so there are subtle things here. I know Jason would want very clear-cut messages to go across, and he's right in that. But we need to realize that the outbreaks that we're seeing in care homes tell us that there are people in those care homes who are circulating and spreading it. And, if one of these elderly residents is exposed to it, they are much more likely to get it. And the nurses may then spread it unwittingly. That's clearly what's happening. So the same thing applies to care homes, I think, as applies to the population in general.
Thank you.
Okay, thank you, Monica. My next question is from Shona Robson, please.
Good morning, and good morning, Sir Harry. I wanted to ask about deprivation. I don't know if you've managed to see some of the evidence emerging from the Office of National Statistics this morning, which it shows yet again a very clear link between social deprivation in terms of incidence, deaths, and of course what we're also beginning to understand and be aware of is the additional impact of lockdown on people who are living in the most deprived communities for some of the obvious reasons that we know about. So first of all, just to hear your thoughts, Harry, on what about that, what that tells us, the learning, the advice in terms of coming out of lockdown in relation to deprivation. And also you talked about social recovery in your opening remarks. What are your thoughts around social recovery, given this has had a disproportionate impact on the poorest in society?
Sure. So the deprivation thing is, I would have predicted this, because we know that healthy life expectancy is 10 to 15 years less in people at the lower end of the socioeconomic scale compared to those at the top. And it's 10 to 15 years less because they develop significant health problems earlier on in life. So a 50-year-old from a deprived area has the same kind of health profile as perhaps someone who's 60 or 65 living in an affluent area. So they are more likely, we know that people with underlying health conditions are more likely to get sick and die with this virus. It's an interesting element from my point of view. When I was a surgeon working in the Royal Infirmary in Glasgow, we did a lot of studies on the metabolic response to illness and infection and so on. And we showed that the lower down the social scale you were, the more vigorous those responses were, the more vigorous their inflammatory responses were. And in fact, this is what we're seeing. The COVID virus creates we call it a cytokine storm, cytokines being the inflammatory markers of the response. And therefore, there is a biological impact which is greater in the lower at the lower end of the social scale than those in the upper end of the social scale. So this is absolutely predictable. And what I will be interested in seeing once all of this is over is, does it have an impact in widening life expectancy in the population? I suspect it will have. So we need to understand that, and I can't immediately see any way in which we can avoid it just now. There are studies going on, I know, particularly in France, where they're looking at anti-inflammatory drugs that might be useful, and early reports that I'm getting from the researchers suggest that it might actually have some kind of impact, but that's stuff going on at this present time. Your other question, the other point you were asking, sorry?
I was asking about impact of lockdown on the most deprived and also social recovery. You mentioned social recovery in your opening remarks. What are your thoughts around that we want not just a new normal, but a fairer society potentially? Yes.
Absolutely. So the new normal concept, I am absolutely 100% behind. What I am seeing just now, I mean, when I go out for my walks and runs or whatever, I'm fortunate enough to live in the country, and therefore we've got lots of space and people really respect the social distancing and so on. But you always get a smile, a hello, a quip and so on. I get the sense that social cohesion, people are talking to each other, they're caring for each other more. I also get the sense that people are using local suppliers, phoning round, getting click and collect or delivery and all this kind of thing. I get the sense that people are becoming more communitarian in their approach to things. And I would hope that as things improve, that will be maintained, that we do help our neighbours who are struggling, that we continue to look after each other in a positive way, and also that we look after the planet a bit better. I mean, the last couple of days when we've seen blue skies, I mean, normally you would see vapor trails up there crisscrossed with flights going backwards and forwards to North America. Skies are clear. And so there is an opportunity to be much more positive in the way we care for each other and care for our environment much more positively. And I would hope that politicians can come together and see that as something that they want to support, rather than just let the economy rip again. Do it in a way. We talk in Scotland about inclusive growth and the wellbeing economy. I've been doing a lot of thinking about how that can be delivered effectively, and I think the time will be right to do that as we come out of lockdown successfully. We don't want to ease up and begin to see a new peak coming. We want to do it in a way that manages happens. And if we do that, we can pat ourselves on the back, start to design a new, much more supportive and caring society.
Just finally, Sir Harry, the public's engagement and support through all of this is going to be critical. Is there any advice you would give around, how do we keep the public on board, particularly as it feels sometimes it's a bit fraying at the edges around people's frustration of lockdown? What's your advice about keeping the public on board?
Well, I think be positive. You send the message that we're all in this together. We all have to work with each other to support each other if we're going to get out of this. I think this kind of selfish behaviour that we see from time to time, I mean, I just maybe a sort of optimist by nature, but I think if you apply to people's good nature, then you're more likely to get more people behaving appropriately. And if you don't, then you've always got Police Scotland to go in and break up the house parties, which I think we should continue to do that. We need to preserve a degree of social distancing for easing up on lockdown.
Okay, thank you. Thank you, Shona. Next on my list is Beatrice Wishart, and after that, Stuart Stevenson. But first of all, Beatrice, please.
Thank you, Convener. Good morning, Sir Harry. Could I ask you about adverse childhood experiences, domestic violence, parental mental illness, physical and emotional neglect, and much more? What are your thoughts on the legacy of what this pandemic might be in those terms? And if we're thinking about ACEs being stressful or traumatic experiences that can have a huge impact on children and young people, how should we go about thinking about their loss of freedom, their worry for loved ones, removal of valued contact, the loss of exams, as you mentioned before, and the other things that children are currently experiencing?
Yeah, very, very good point, and something that I've been thinking about a lot. So we need to identify fairly early where this kind of thing has been occurring. And again, I come back to the idea of the improvement approach that we applied in the early years work and so on, that led to significant reductions in infant mortality and so on. What long and careful study and discussion with people who have experienced ACEs tells me that the lasting damage that is done to children is basically around the concept of learned helplessness. These children are told that they're useless and, they go to school and they don't do well, and that reinforces their sense of helplessness and so on. And when you speak to young people who've been in trouble with the police and have maybe been to prison themselves and so on, what they say has transformed their lives is someone coming along and telling them, you're not useless, you have skills, you have abilities and so on, and helps them take a sense of control over their lives. And I think that's an important thing that we could be working on over the next couple of years. Identify the children who have experienced trauma during this time and make sure that we support them in ways that enhance their sense of self-esteem, sense of control. And if you do that, not only will you create a young person who is positive about the future, but they will do well at school, and they will go on to have make a very positive contribution to society. So I think those of us interested in ACEs, one of the things that might come out of this is get us together and come up with a set of policies and actions that will reinforce the sense of control in children experiencing turbulence at this time. Don't leave them to fester with the legacy of what they've experienced at the moment. Get in there and tell them, no, you can take control over your life.
That's really interesting. I mean, I totally agree with it. You just see the lifelong damage that it can do to people. But how do you think services can adapt to the scale of what might be coming their way in the months and years ahead?
Well, again, the whole theme of an improvement collaborative is let the frontline staff come up with the ideas, test them, see what works, and then implement across the whole system what works. The last thing I want to do is try and tell these people their business. They are working day and daily with these problems, and they will have ideas. And our early years collaborative, some of the ideas they came up with were absolutely brilliant, but ministers would never have suggested them. But the frontline staff knew what they needed to do, and when they tested, some of the things they tested didn't work. So leave that to one side and move on to things that did work, and then share the learning. So I would try and revitalize this work that will have been put on hold over the past couple of months and really get to grips with it. And we may come out of it in a year or so's time in a lot better position than we would have been without this experience.
Thank you. Thank you, Convener.
Okay, thank you very much, Beatrice. Next is Stuart Stevenson, please, and after that it'll be Adam Tompkins. But Stuart Stevenson, please.
So, Harry, I'm interested in how the numbers are driving decisions that we make. And I'm just going to ask everything at once because it will save time and I think make it simpler for you perhaps to answer. I'm particularly interested in the R0 number, the rate at which people are passing infection on to others. And I suppose the first thing I ask, how confident are you about the R0 numbers we have? There's a danger I see that we're given a single number when the reality is it's the midpoint of a range of probabilities, and the difference at the two ends in outcomes is quite substantial. The second thing that relates to the R0, I'd like your insight, if you have one, on is to what extent it will or will not be useful in helping us have policies and changes to the way we practice social isolation and other public policies by area. Because clearly in Grampian, where I live, we've much lower infection rates than, say, in Glasgow. But is the R0 number going to help us to understand what we might do differently? And indeed, it's a question would imply in Cumbria versus London versus Devon and so on and so forth as well. And are there other numbers that we as parliamentarians should be keeping our eye on besides the R0?
Okay. So the R0 number, I think, is important in our decision making at this time. The latest I heard was that the understanding was it was around about 0.7 at the moment, which is less than 1, which means that there's a declining number of people being tested positive. I would expect it to go up when we ease lockdown, because people will be getting together unless we have a very effective tracing and isolation approach. I would probably like it to be a bit less than 0.7 because, as I say, I think you're absolutely right, it will oscillate a bit and you would expect it to go up. So it would be nice if it was down below 0.5 or something like that, but that's maybe me asking for too much. You're correct, it will be different in different communities that, if we were able, and statistically it's probably not possible to do it at a very small scale, but for example, multi-storey flats where people are sharing lifts and so on, where it's difficult to socially isolate and so on, that should have a higher R0 than, a suburban upmarket area where people have big gardens and can go out and not be close to people. So there will be variations, and you're right, variations in country communities compared to city communities will be significant. Unless you're prepared to shut the border and grab paint, I just don't think that I just don't think that we would be able to control that. You saw all the camper vans going up to the Northern 500 and so on at the beginning of all of this. Well, that's just daft to do that. But, we've got to have some degree of freedom as we lift the restrictions. So, yeah, we accept that R0 will vary by the density of the population in different places, but we just have to keep an eye on it across the whole of Scotland. Will it be useful in driving changes? Yeah, I think if R0 starts to go up, the calculation on this will usually occur a week or two behind what's happening because we're collecting the data as we're going. We need to be prepared to tighten restrictions if we see things going up too rapidly as lockdown is lifted. So that would be how you would, I don't know if you would use the R0, but you would certainly use the number of detected cases on a day-to-day basis as a way of monitoring the safety of loosening restrictions. Does that help?
That is helpful. I want to just very briefly go back to one specific thing you said, which was referring to the tower block and how R0 might be used there. And just to question whether it's useful in small enclosed communities, because obviously you run out of people to infect quite quickly. So you would see quite a rapid decline in the R0, which is a false understanding of what's going on. Yeah. So in a case where R0 comes down rapidly, we shouldn't assume all's well. Is that correct?
Yes, you need large numbers to be sure that you're collecting a sensible R0. I'm just using that as an example of where transmissibility you would expect to be greater in that small community, just to make the point that the conditions in which people live will have an impact on the transmissibility of the virus. And what you're talking about, if everyone in the tower block had been infected, then what you've got there is herd immunity in that tower block, and the R0 would fall quite significantly thereafter.
Okay, thank you. Thank you, Stuart. I'm going to move on to Adam Tompkins, and after that, Annabel Young. But firstly, Adam, please.
Thank you, convener. Good morning, everyone. Good morning, Sir Harry. Clearly, as we take steps, as the government takes steps to begin to ease the various lockdown restrictions, what the government is seeking to do is to balance various different risks against each other, and just focusing on the health risks, leaving to one side for the moment the undoubted economic pain that lockdown is causing, just focusing on the health risks. I'm pleased that the public conversation around this has started to engage more seriously than it did perhaps 2 or 3 weeks ago with the risks associated with lockdown itself. Mental health risks, cancer referrals down, A&E down, cardiology wards operating at something like 50%, all the rest of it. But this is all now in the public domain being thought about. But what I'm beginning to get increasingly kind of confused about, and I wonder if you could help me with, is exactly how we are to assess the risks with regard to COVID itself. Because it seems to me that lockdown was introduced in order to protect the NHS from being overwhelmed. Now, isn't it the case that the NHS is really a very long way away from being overwhelmed by COVID? The most recent statistics are, for example, that there are 89 patients in intensive care in Scotland with COVID, and intensive care capacity is 585. That means that we are operating at 15% capacity. Now, am I right to interpret the figures in that way? And if I am right to interpret the figures in that way, then can you explain to me why it is that you think that the government is wanting to proceed so cautiously in beginning to ease the lockdown restrictions, given the health costs that we know that they're bearing?
So I don't agree that lockdown was introduced to protect the NHS from being overwhelmed. I don't think that was the primary purpose. The way you stop the NHS from being overwhelmed is to stop huge numbers of people becoming infected. And the prime purpose of lockdown was to stop transmission of infection. And one of the consequences of that was to stop the NHS from being overwhelmed. I think the NHS was overwhelmed in some places to begin with, and the stories I'm hearing about the decisions that intensive care doctors had to make about who got the ventilator and who didn't were really quite heartrending. But I think, the fact that you see the press conferences with, stay home, save lives, protect the NHS kind of thing, that message is coming across. And that kind of, the way to protect the NHS is to stop people becoming infected. And the lockdown was there to stop people becoming infected. So you lift lockdown, you run the risk that more people will become infected and more people are likely to die as a result. Now, my desire in all of this is to stop people dying. I think you're absolutely right. If we lift lockdown, I don't think we will get back to the peaks that we saw at the beginning, and I don't think we will come anywhere near swamping intensive care capacity. But if it goes up, then that's more deaths that are potentially avoidable. The trade-off, you rightly say, is, well, some folk are staying at home because they're not getting treatment for their cancers and so on, and therefore they're more likely to die. So we have to balance that, and we need more analysis. We need more data. I am having discussions with colleagues about that. The back of the envelope calculation would suggest that there were perhaps a couple of hundred deaths a week more than you would expect during March from non-COVID related causes. We need to see what those causes were, and we need to get on top of them as soon as we can. And I think the next challenge for the NHS is to organise those services so that cancer surgery, heart surgery, coronary care systems and so on become safe for patients. That patients feel secure that if they go in there, they are not going to be infected by coronavirus. We need to make sure that that is in place properly, and that's the next challenge for the NHS, switching services in a way that protects people who need care for these other conditions. And that's happening in some places, but again, share the learning. What did they do in Edinburgh that they could do in Dundee, etc.?
I'm grateful for that answer, Sari. Thank you. But I'm not sure that you're right that the government. I mean, Jason Leach, for example, has said, I think, many times that the purpose of the lockdown was to prevent the NHS from being overwhelmed, and that's a line which is used several times in the paper that the government published this week with regard to its framework for decision making. But you say that we need more data. Where are we going to get this data from, and how quickly are we going to get it? Because I'm not an oncologist, but we all know that cancer survival rates depend on early detection and early treatment. And when we've got this stark reality that cancer referrals from primary care are down 70% in Scotland, we know whether we like it or not, we know that the lockdown is killing people. The lockdown is killing people because it is preventing people, inadvertently I'm sure, but it's preventing people from getting early cancer treatment that has the potential to save their lives. So, what is the data that we need, and how quickly are we going to be able to get it in order to prevent the lockdown from doing more harm than good?
Yeah. So come back to the line, protect the NHS. Yes, that's a very catchy line. It's one that appeals to people, and the Thursday night clapping and so on tells you just how important the NHS is in people's minds, and it's a good PR line. But as I keep saying to folk, the way to protect the NHS is to stop people becoming sick, and that's about controlling coronavirus, and it's about getting the rest of the NHS back into full swing. The fact that elective surgery has been cancelled and so on is a reflection of the fact that people have felt that it's dangerous to bring folk into hospital where there might be cross-infection with coronavirus. We need as quickly as possible to establish areas within hospitals that are safe and secure and not subject to cross-infection. And that is the next phase. That's an important phase of lifting the lockdown. And in terms of the data, every single patient who comes into hospital has a form called the Scottish Morbidity Record filled out that tells you what they're in for, what their outcome has been, and so on. And that data continues to be collected. Scotland has one of the best data collection systems of any health service around, and people I know are working on analysis of that data now that will tell us just exactly what's happening with these other conditions. And I agree with you. I think we will become quite depressed at what we see, which I completely agree. The sooner we move on and get to a position where the NHS can support these people, the better. But we know how to do that, and we should apply it ASAP as part of the lifting of lockdown.
Okay, thank you. Thank you, Adam. Thank you, Sir Harry. Monica Lennon would like to come in with a brief supplementary, please.
Thank you, Convener. Yeah, just to pick up on Sir Harry's answer there, Adam Tompkins is making obviously really important points about how we can get the NHS up and running again. If the NHS starts to see much more patients, I imagine that would require additional PPE. If there's more people in the hospital and more procedures and so on. There's been a big concern throughout this pandemic about access and supply and distribution of PPE. Can Sir Harry Burns say to what extent PPE resource might be a factor in terms of getting the NHS up and running again, and how confident is he about PPE supplies going forward?
So I don't think it necessarily needs more PPE. The people coming in for cancer surgery, for example, you test them when they come in, you know that they're not positive, and the clinicians involved in their care should be tested, so they're not positive. So if they are in a part of the hospital where it's separate from where the coronavirus patients are being looked after, then it would be business as usual. I think you try and establish business as usual as quickly as possible. You do not need PPE for dealing with patients who are not coronavirus positive. For example, patients who have symptoms of coronavirus in primary care are referred to a hub. Patients who don't have symptoms are referred to their GP. Now, their GPs are wearing gloves and masks and so on at the moment because those patients are not tested. But once you know they're negative, you don't need PPE. So I don't think that becomes a limiting factor in getting the NHS back to business as usual.
Okay, thank you, Monica. We'll have to move on. Next question from Annabel Ewing, please, and after Annabel, it'll be Ross Greer. But Annabel, please.
Thank you, convener, and good morning, colleagues, and good morning, Sir Harry. I've got two questions. One, picking up on the discussion on the R0 number, and I just wanted to ask if there is any change to current lockdown restrictions, and then there could be a second wave of infection, and looking at that territory, what kind of benchmark, very broadly speaking, would be where we would arrive at that would require going back into a more restrictive lockdown? I think my colleague Stuart Stevenson talked about our zero number, and I think Sir Harry also was at pains to stress that it would be looking at the increase in the number of cases. But what kind of benchmark, and for what sort of sustained period statistically would that be necessary to look at? Just because I think people really want as much information as possible, to the extent that it's possible, in terms of, well, let's plan for this, but then if that doesn't work, I think, and the First Minister is at pains to try to treat people as grown-ups. And I think it's that kind of information, even though it could be speculative from a scientific point of view, that people would be really interested in hearing about.
So one of the things we could do is learn from what's happening in other countries. Spain, Italy, Germany, and so on have had limited lifting of the lockdown, and we should be able to see what's happening there and learn from that and decide, are we going to get another peak as big as the one before? I don't think so, but will we get an increase in cases? Probably. So that's a matter, I think, for broader discussion as to what would be acceptable. You don't want to see any deaths at all, ideally, but I think it's inevitable that you will see more infection as we lift the lockdown, but hopefully we can keep that as low as possible. The R0 number, as I say, that would be calculated a week or two behind the data. So the number of cases being admitted to hospital and testing positive, I think, would be a reasonable number to follow and give us the earliest indication. And, I think that if we began to see it going up in a way that suggests that the R0 is getting closer to 1 again, then we really need to put the brakes on.
Thank you for that. I mean, my impression is, it's an impression that for those people who are in vulnerable groups for whatever reason at the moment, they're very leery indeed about moving to some next stage, that they're not entirely convinced, to the extent that you can have a reasonable position at this point. They're very leery about that, really concerned.
Absolutely agree with that. I'm leery about it. I'm the carer for my 96-year-old mother. I'm the only person she sees. I go in and help her out each day, and as a result, I don't go to shops. I don't, I kind of self-isolate myself so that I'm not taking anything into her. If suddenly it was all lifted and I was in a situation where I was going in, I was having to mix with other people, then I don't think I could go in and look after her. So yeah, I understand why people are concerned, and I share their concern. So we need to tread carefully with this. And, come back to the point that others have made. There is a big trade-off between the number of folk who are frightened of going to hospital and dying as a result, and the economic damage that's being done and so on. But yeah, we've struggled hard to get where we are. Let's not throw away the gains that we've made. Let's do this carefully and sensibly.
Yeah, absolutely. And my other question, it's a slightly different topic, if I may, convener. So obviously at the moment, the international scientific medical community is working very hard indeed on seeking to secure an antibody test that works. And I just wonder what would be, into Harry's viewpoint, the interrelationship between the test trace policy and the lack of, at the present time, an antibody test. What would be the impact on the efficacy of test trace without that other component? Or is the interrelationship not so direct that it would have any particular deleterious impact?
I think it would be useful to do both. And I know that there are some tests in development that can actually measure both antibodies and presence of virus, so that you've got the virus and you're beginning to mount an antibody response. I think the importance of an antibody test would be to show that resistance to the virus lasts for some time, which means that those who've had it, it's safe and have the antibodies are possibly safe to go back to work and so on. But the key thing with the existing antigen test, the test for the existence of the virus, trace and isolate the contacts to push that R number down as low as possible and to conceal the spread. That's what we've got just now, and that's what we should focus on, I think.
Thank you.
Okay, thank you, Annabelle. Ross Greer, please, and after Ross it'll be Willie Coffey. But Ross, please.
Thank you, convener. Good morning. You may be aware of some comments, a suggestion that Professor Hugh Pennington made to Parliament's Education Committee last week, that instead of pursuing a suppression strategy, that we in Scotland, I think he would advocate this across the UK, should pursue a more aggressive elimination strategy for the virus, similar to what's been achieved in New Zealand or perhaps Vietnam. And his suggestion was that we could see effective elimination by Christmas. I'm interested in your thoughts on that proposal, whether you would agree with him, and what a suppression strategy, what a suppression approach might look like compared to what an elimination approach might look like compared to our current suppression approach.
Well, I mean, the whole idea of suppression, I think, is ultimately to lead to elimination. You do not want small pockets of this virus hanging about. The elimination really would occur when you've got a vaccine. And I think that, well, we're assuming it's months away. So I'm not sure that we have an elimination mechanism just now beyond continuing to suppress and stop the virus being passed on. The virus, viruses that kill lots of people tend to die out themselves very quickly because they've killed all the available hosts. This virus has killed a lot of people, but it's still infecting folks, which implies that it's a very, very resilient virus. It's out there and lots of people are carrying it about without symptoms and passing it on without knowing that they're passing it on. So until you know who's got it and until you can isolate them, elimination, I don't think, is going to be very successful until we get a vaccine.
So on that point then of this being a slightly more nuanced, rather than saying these are two completely separate strategies, they're being a little bit more nuanced. The examples that have been raised, New Zealand is the most notable one that's being raised here, I think simply because it's another English language nation, so the media transfers very quickly, but others like Vietnam have also been raised. Is there a significant difference, you believe, in the strategies being taken there and here, or is it simply that they have been able to bring test, trace and isolate capacity online in an aggressive form far quicker? It's not a significantly different strategy, they've just done it far quicker.
Yeah, I think they've done things. I don't think it's significantly different. I can't see, and I've looked at what's happening in New Zealand, and I can't see that it's qualitatively different. I think quantitatively, yes, they have been more successful at isolating. Control of borders, I think, is important. I mean, we had all this stuff about 8,000 people a day coming into the UK without being tested, whereas in South Korea and so on, you saw people having their temperatures checked by infrared mechanisms as they came off aeroplanes and so on. They seem to be far more aggressive in terms of identification of people who might spread it. And that's why the testing is important. Test people to see who's capable of spreading it, trace their contacts and isolate all their contacts as well as them. That's the way in which you control any infectious disease. The smallpox outbreaks that occurred in the 1950s, the tracing and isolation, the people I know have spoken to, the old stagers who were around at that time, say that the tracing was done very aggressively because smallpox killed people in a very nasty way, and the only way to treat it was to eradicate it. So you could eradicate it with significant effort put into tracing and isolation. And that, in essence, is what lockdown did. It was isolation without the tracing.
Very briefly on that point on testing, do you believe, should we be testing all frontline health workers, whether they are symptomatic or not, on a routine basis?
I think we should be testing, this might sound ridiculous, but I think we should be testing the whole population. I think we need to know how widespread the virus is in the population. Once you know that, who has not, who might still be out there that could be infected and so on. But yeah, we need on a regular basis, the point has been made several times that a test today doesn't necessarily mean you're not positive tomorrow. So we need to be looking at the folk who are capable of spreading it, and those are predominantly health and care workers, and we need to be testing them on a regular basis. But come back to the point I made at the beginning, you need a bit of quality assurance in the testing process to know that it's been done properly. And anecdotally, what I hear is that actually it's volume rather than quality that might, in some cases, have been more important.
Thank you.
Okay, thank you, Ross. And Willie Coffey, please.
Thanks very much, convener, and good morning, Sir Harry. My question is, in a sense, a follow-on from the previous member's question that was leading there. The Scottish Government paper issued this week tells us that there are still around 26,000 people or so in Scotland that are currently infectious, who presumably don't know this yet. Do you think we can do more, try and find more of them so that it helps us to bring this situation under control, or are our only weapons lockdown, testing those most at risk, and managing those who present with the symptoms through the process?
Yeah, so 26,000 people, I mean, this virus is so infectious that it wouldn't surprise me if the figure was much greater. Initially, it looked as if the mortality rate was about 1 or 2%. And, given the number of deaths that we've seen in Scotland, then that would suggest that a whole lot more people than that have had the infection and are not aware of it. I come back to the testing, widespread testing. And this is where the antibody test comes in, because if you're doing both, you will find both the people who are currently infectious, but you will also find, in all probability, the number of people who've had it recently, As I say, we still don't know, I think, how long the antibodies remain in bloodstream, but you will begin to understand who's had it and is probably immune, who's got it and is capable of spreading it, and you will begin to understand what proportion of the population are susceptible to it. And if you keep the second group away from the third group, then you have a chance of eradication. So it's back to the testing.
If the lockdown and the current testing strategy is successful and begins to diminish the numbers that are presenting and so on, how long do you think it should be before that 26,000 number, if it is around there, how long does it take to diminish to a level that the Scottish Government can seriously consider some of the options for relaxation of the lockdown that are also set out in the paper?
Well, we're seeing a decline in the number of deaths in hospital. We're also now seeing a decline in the number of deaths in care homes and so on, which implies that the present strategy is working to control that number. What we are now seeking to do is essentially do lockdown in a more targeted way, and that's where the tracing and isolation bit of this comes in. It's targeted. Isolation is simply targeted lockdown for those individuals who have been in contact with those who are positive, and you isolate them for 14 days, and if they've got no symptoms, then they can get back out into work. And clearly we need to be doing that for the reasons of ensuring that economic activity goes on, that mental health improves, that people who are frightened to go into a hospital and suffer as a result get proper treatment. There are pressing needs to do this. We need to do it carefully, and we need to be prepared to step back if we see things getting out of control again. And that requires, as you say, testing and identifying those 26,000 people out there who may be positive or who have had it, and understanding who's capable of spreading it. So it's old-fashioned public health. Go out, test, find out who's got it, and isolate them from people who don't have it.
Okay, thank you. Thanks, convener. Thank you.
Okay, thank you very much. I don't see anybody else wanted to come back in, so I'm very grateful to you, Sir Harry, for your time this morning, and I appreciate you giving evidence, and I'm pleased to see the technology seemed to work fairly well, at least at this end. So thank you for your time, and no doubt the committee might want to speak to you again at some point in the future.
Okay.
At this point, I think we'll have a short suspension for about 5 minutes, and then we'll hear from Professor Linda Bold, but we'll take a break just for a few minutes. Thank you. Right, well, welcome back to the COVID-19 committee. We are now going to take evidence from our second witness, and I'd like to welcome Linda Bold, who is the Bruce and John Usher Professor of Public Health and Centre for Population Health Sciences Co-Director at the University of Edinburgh. So welcome to Professor Bold. You will have heard, I'm sure, the evidence session earlier with Professor Sir Harry Burns, and I'm sure we want to go over some of the same ground again. But before we get into that, is there something you would like to say by way of an introductory statement?
Yes, thank you very much, and good morning, and thank you for asking me to join the session. I think I just want to echo some of the things Sir Harry was saying. Now is not the time to look back, but now is the time to look forwards, and I think that's what we're doing today. And there's an opportunity to think about how Scotland can move on from the current public health measures that we're all facing and have been challenging for families and communities. But I just wanted to highlight some of what I think are the positive things that we're seeing. I think our population, all of us, are realizing the importance of public health for our well-being, for society, and also to protect the NHS. I think we're seeing and realizing that this is a global crisis that requires a global response, and that Scotland has a place in that. And I'm sure MSPs will be asking questions about international examples and what we can draw from that. I also think that the scientific community has responded in an unparalleled way. We are practicing open science at speed in a way we haven't, certainly in my working lifetime. And I think that's something that is positive and will have benefits in the future as well. And then the final point I just want to make as a behavioural scientist is we heard some of the MSPs asking about communication with the Scottish public. And I think we've had some strong and clear communication to date. But as we move out of this current period, it's going to become much more complex. And we're going to have to be much more nuanced in how we communicate to the public so that they have trust and they also know, the changes and how they can move on and how they can cope in very changed circumstances in the future. I think that's it for my opening remarks.
Thank you very much. Can I maybe just start off and pick up on that last point you made about communication that I think is really interesting? Because there has been this discussion around differential approaches to lifting lockdown, either different parts of the UK going at different speeds, or indeed even within Scotland, different areas moving at different speeds. And I wonder what you think about that in the context of this issue about communication, where, is there a danger that, the public are hearing different messages coming out from different sources? And that just causes a lot of public confusion, and maybe we would be better just sticking with one common approach, even though the science might not necessarily lead us to that conclusion.
Well, I think the four nations approach that we've seen in practice, which has not always been the case in the past, is welcome. And I think when you're facing a common threat, this virus and the disease that emerges as a result, it makes sense to do that. However, as we move on to releasing lockdown and thinking about the longer term, I think there probably will be an opportunity for more variation. So I think Sir Harry was already pointing to the fact that there will be communities in Scotland where we see lower levels of virus transmission, fewer cases, or indeed higher evidence of immunity. And if that is the case and we have the data, and I will talk a lot about the data because I do not think we have the data that we need, and we need to focus on that, and then it may well be that we need to take a more geographical approach and have different measures in different places. So I think the time for that will come. I don't think the time for that is now, however. I think clear messaging is still needed. But I think that one of the things we know from research is that the public can actually cope with uncertainty. They can still trust public messaging when they realize that elected members and others are being honest about the fact that they do not have the answers. And I think we all know in this circumstance with a new virus and new condition disease that's emerged as a result, we don't have all the answers. So as long as the unknowns can be communicated and we can be honest about that, I think that the public will still recognize where we have certainty and where we don't. And also if we can be honest about the basis on which we're making decisions and providing advice, that also increases trust.
Thank you, that's very helpful. And I'm sure some of my colleagues will want to pursue some of that in more detail. I wonder if I can ask you the same second question I asked Harry Burns earlier, which is around what is sometimes portrayed as a trade-off in terms of lifting lockdown between saving lives and saving the economy. But in actual fact, I suspect it's more complex than that, because as we were discussing earlier, although we might be saving lives in terms of COVID-19 patients, I think the figure Harry Burns quoted was he reckoned something like 200 to 300 extra deaths in March due to other conditions, because people are not coming forward with issues like coronary heart disease or cancer, and that's not being treated. And that doesn't even touch on the wider issue of mental health, where we have a huge concern about the mental health impacts of extended lockdown, particularly on single people or those in isolation. So I don't know if you have any thoughts on that. How do we make sure the debate on lockdown isn't just seen about money, the economy versus saving lives? There's other health issues here too we need to think about.
I'm very concerned about this, and I think I would even word it more strongly. I think that the consequences of the lockdown period and the longer term consequences of lockdown for our young people, for jobs and the health impacts of unemployment, for example, in the fullness of time, I suspect may emerge as far greater than the challenge we faced with addressing this virus. And I think we're already seeing some of the evidence of that. So the way that I would describe it is not lives versus the economy. It's lives versus lives. That's what we're facing. So we've already heard about the drop in urgent referrals for cancer of over 70%. We know that accident and emergency admissions are down by about half. We know that hospital admissions full stop are down by about 42%, looking at the latest data from Public Health Scotland. So it's very obvious that the message, stay home, protect the NHS, has been interpreted as stay away from the NHS to protect it. Now, the Scottish Government and others have been much clearer in the last couple of weeks about people accessing the health service and that it should be there for them. But I think that that's probably a priority issue we need to focus on now. And the longer we remain in the current lockdown situation, the worse those consequences will be. The latest data from NRS actually coming out, I think just yesterday or the day before, suggests that we probably have around 1,000 unexplained non-COVID deaths, which is a significant number, not the same as from the virus, but it's still there. But the longer term health impacts, I think, will take many years for us to realise. So one of the things I'd like to come to, and I'm sure members will ask me questions about this, is how we support the health service to move on. And my particular expertise working with Cancer Research UK will be on cancer, but there are other examples we can draw on as well. I'm sure we'll come to some of that evidence.
Great. Thank you very much. That's very helpful. And I'm sure my colleagues will want to come in with more questions around these areas in a moment. I'm going to move on next to Monica Lennon. After Monica, it'll be Willie Coffey. But firstly, Monica, please.
Thank you, Convener. Good morning, Professor Bald. If I can pick up then on cancer, first of all, and I know you have a great deal of expertise in this, there has been a lot of concern expressed about the pause to the cancer screening programme, but also to other procedures and for people who are worried about cancer, possible cancer symptoms. So I just wondered what your advice is on that. What would you advise government, and how quickly do you feel that we should resume these screening services? And if I can maybe reflect back on Sir Harry Burns's comments about the health service, I asked if it was a possibility that concerns about PPE supplies was a factor in terms of trying to sort of minimise contact within the NHS. You know, in your view, you know, do we need to factor that in? And also, Harry Burns said that, you know, if we're doing testing within the healthcare service, that would help. But in my experience from casework, speaking to both patients and NHS staff, getting the result isn't always quick. And I'm aware of cancer consultants who've had to self-isolate for 7 days and 14 days because they hadn't been tested. So I just wonder if you've got any thoughts on that.
Sure. So you've asked, I guess, 3 issues there, Monica, and thank you for those questions. So bear with me because I've got some new statistics I just want to share with members on the cancer front, if that's helpful. So we know that usually there's around, in terms of the pause of screening, if I just deal with that first, we normally are screening around 23,000 people a week. That's 100,000 people a month are no longer being screened in Scotland for the 3 cancer types you're familiar with: bowel, breast and cervical cancer. Now, around 140 of those would normally get a positive result each month via a screening programme. So if we imagine that that's basically paused for 2 months, that's 280 potentially late diagnoses. And I think one of the members quite correctly commented later that for many types of cancer, early diagnosis is basically what determines survival and treatment outcomes. So unfortunately, some of those patients will have poor outcomes, and that is a direct consequence of the lockdown. And just to put it in perspective, for the rates of death at the moment, you're still seeing about 1 cancer death for every 2 COVID deaths in Scotland. So cancer is still there, it's not going away, it still needs to be addressed. So in terms of urgent cancer cases, we know there's around 2,000 urgent suspected cancer referrals that are not happening each week in Scotland. So again, that's of real concern. And we think chemotherapy is down at around 30%. And you will have seen the data, Monica, from the Royal College of Surgeons of Edinburgh that suggests that 1/3 of cancer surgeons have stopped operating completely, and over 80% have significantly reduced it. So those are absolutely real concerns. And I think if you just bear with me in terms of trying to address that, there are some very practical things we could do moving forward. The first one would be to restart those screening programs, and I know, speaking to colleagues involved in them, that they're ready to do that when the time is right, and they need good advice from boards and Scottish Government to do that. But also to try and protect our cancer patients and our healthcare staff working in cancer settings. We need COVID-free either zones or hubs, which will allow the vulnerable cancer patients who will be more susceptible to adverse consequences if they get cancer to be treated in those environments. So we need to have some separation of NHS care. And that moves on to your PPE question, which I think is absolutely crucial. And I know Sir Harry made some valuable points about PPE, but unfortunately, I still remain extremely concerned about that. Now, just to be clear, I am no expert in the procurement or the specifics of what is required. But I did organise a session with colleagues from China for the Usher Institute, including the author of the COVID Prevention and Treatment Handbook. And when you look at the type of PPE that they use in China in various healthcare settings, particularly settings where very close contact with patients is happening, it is a level above what we currently have in some of our settings, even setting aside the social care discussion, which I realise we might come to. Now, I don't underestimate the logistical challenge this has been. We've all read about it in the press, but we really need to take this seriously, and we also need to recognise that this is not going to go away, and PPE is going to be something we need to continue to have an emphasis on in the future. And then just in terms of testing, again, some other new data I have is I think one of my big concerns about testing in terms of what my expert colleagues have been telling me is speed, as you say. So Harry rightly pointed to the accuracy issue, which is entirely appropriate, but the speed issue is also very significant. So when we come on to our discussion about test, trace, isolate, which I'm sure we will do, we have a big problem with that, because I think it's about 30 hours, something like that on average, from a test being taken to a result. Other countries are doing it in 4 hours time. So we absolutely need to look at our testing mechanisms, but also our speed of delivery of an accurate result. Because if we want to test, trace, and isolate, we're going to be too late for the tracing and isolating component if we haven't got the testing speed, faster than it currently is.
Thank you, Linda. That's really helpful. There's quite a lot to chew over there. I've only really got one other question that I'm allowed at this stage. If I can switch to something else, picking up on your behavioural science expertise. There's been discussion at this committee and elsewhere in Parliament about the age-based restrictions, or the perception around that older people, particularly those that are over 70, really should be staying at home as much as possible. So I understand the difference between people who are being asked to shield because of health conditions, but for the over 70s, we know that people, it's a long day if you don't see anyone. People are very worried about becoming vulnerable to fraud, for example, or just the mental health impact. So how realistic is it to expect a particular age cohort like the over 70s to effectively, shut themselves off from society? And as we go forward, I know there's legal opinion about this, about whether or not that is lawful, is it discriminatory? But from a sort of behavioural point of view, how realistic is it to expect people who are over 70, who might be business owners, who might still be in employment, who might have other caring responsibilities, how realistic is it to expect them to isolate on a long-term basis?
I don't think it's realistic, and I think it is discriminatory, but I also understand the reasons behind it. So from a behavioural science perspective, cutting off a big section of our society who are otherwise healthy is not sustainable in the long term. And you'll see non-compliance, basically, that's what's going to happen. So I think that in terms of public messaging going forward, the people who have underlying health conditions, I think we are absolutely a priority. And as you know, that's not always age related. But just looking at a number in terms of age, it might be useful for simple messaging and guidance, but it's not fair to treat all people over the age of 70 the same. So I think we can give guidance and advice, but I think the crucial thing for all of us is that we can move out of this lockdown period and move away from those very severe restrictions on particular age groups over a very long period. And the only way we're going to get out of this is if we do the test, trace, isolate, support approach and really take that very seriously and ramp up the system. And I will come on to the data that we need, I'm sure in a minute, to be able to do that. So it's a great question. I'm getting the emails. I'm sure I'm not getting MSPs are from older people who don't want to see those restrictions maintained forever because they're healthy and they feel they have contributions both to the economy and to their families to make.
Thank you.
Thank you, Monica. If you have time, Monica, we'll come back to you later if you have more questions. But I need to move on to bring in Willie Coffey, and after Willie it'll be Ross Greer. But Willie, please.
Thanks very much, Convener, and good morning, Professor Bold. I wonder if I could ask you, are other countries experiencing the same sort of drop-off in presentation of other non-COVID related conditions, and how are they managing that? You mentioned just a moment ago that we might need to think about things like COVID-free zones or hubs. Is that a realistic possibility for Scotland, and should we be beginning to present or prepare a way to try to achieve something like that?
Yeah, so just in response to your first question, Willie, you're absolutely spot on. One of the challenges we have in this area is that data availability varies hugely across countries. So unfortunately, in low resource countries, low resource settings, we're not even really seeing accurate case numbers, etc. We just don't know. But from high income countries like the US, Canada, including some European countries, we are beginning to see those non-COVID death figures. And in fact, The Economist, for example, the publication, just did a recently useful piece trying to pull some of that together. So the problems we're facing are not unique to Scotland, and they're not unique to the UK, because other countries have tried to protect their health service and they've basically cancelled lots of operations and other procedures. So that's why I made the point at the beginning about an international effort, because I think we're already seeing, again in Canada, for example, where they've had fewer cases, and their healthcare systems gradually reopening, and also trying to very clearly separate the pathways for triage and support for COVID patients and other patients, perhaps easier for them with lower numbers. But it's absolutely something that we need to adopt in the NHS and support colleagues to do, because until we have a better treatment for these patients, or indeed a vaccine in the future, we absolutely need to continue treating our other patient groups. And I guess there's two factors there. Confidence for the staff, that they can administer and support the treatments and those patients safely in a safer environment. And secondly, confidence for the patients, many of whom, including cancer patients, have a long trajectory of treatment with multiple visits to healthcare facilities and different types of treatment, to keep coming back and complete that course of treatment if they realize they're in an area where that is safer for them to do so.
Thank you very much for that. I wonder if I could ask you a question on kind of broader mental health. What more do you think we can do to help people through this in terms of their mental health? Naturally, we're concerned across the board, but particularly for people that might live alone, and also for young people, and especially full exam pupils that may be taking exams at the moment, and our university students. What more can you reasonably do to help them through this process and beyond it?
So again, I think we can learn something from other countries there, Willie. So Singapore has 5 pillars to its approach to addressing COVID, and psychological defence is one of those pillars. So as we move forward in Scotland, and of course the government's been very helpful in setting out its basic principles for releasing lockdown, and then more recently some indicators of how that could happen. But I also think we need a pillar or a staged approach which has different components to it, and mental health support is going to be a crucial part of that. I won't run through all the figures which I have in front of me, but in terms of the opinion surveys we've seen, we know there's high levels of anxiety, increased levels of depression, and those vary depending on the age group. And crucially, people who already have a long-standing diagnosed mental health condition are going to be facing particular challenges at this time. So in terms of a psychological defence pillar, a couple of suggestions from me would be obviously that mental health services in the NHS I know in Scotland we've really tried to improve those and resource them adequately, but we still have some way to go. But secondly, and equally importantly, I think our third sector organisations have a huge amount to contribute here. So resourcing them to be able to respond to that, whether it be for young people or older people, will be crucial. So those are just a few suggestions, but let's have an active public debate about a psychological defence pillar, if that's helpful, as we move forward.
Thank you for that. Thank you, Convener.
Okay, thank you, Willie. Next, I'll bring in Ross Greer, please, and after Ross is Annabel Ewing. But Ross, please.
Thank you, Convener. I'd just like to pick up first on one of the points you made in response to Monica Lennon around the speed of returning a test. There appears to be quite a significant underuse in the capacity for tests in Scotland at the moment, even if we're accounting for individuals being tested twice, etc. I'm wondering if that is related to the length of time it takes to return the results of the tests, and if you have any thoughts on why this might be the case, why it appears that we're, in some cases, on some days recently, quite dramatically underusing Scotland's testing capacity, and how that could be addressed.
Certainly. So there are others who are closer to the testing infrastructure than me. I would just emphasise that. But certainly discussions with my more expert colleagues that would suggest a few things. Certainly speed is an issue, but also location is an issue. So we were very slow in the UK, and this is not a comment for Scotland specifically, on increasing our testing capacities. I think all of us in the meeting today know that we should have been ready much earlier and really embrace the offers we had from the private sector, from the third sector, universities, etc., to increase our testing capacity. And we're still not there yet. And of course, the First Minister has set indicative targets for Scotland, as we've seen at the UK. So part of it is location. As I think you're aware, Ross, that people can't get to the testing centres easily enough, and that's a big barrier. So we need to have far more of that. And as Harry has said, we need to have community testing as well. I think this is probably the right time for me to bring in some of the data issues that I wanted to raise, if that's okay with you, around how we have basic parameters that really are not there. So we need real-time data flows. So just on testing for a minute. So we look like we're getting it right in hospitals. That's great. So that's a tick, I think, on that one, from what I understand of the system. We have limited information from high-risk settings. So that's care homes and other settings where you have vulnerable populations who particularly urgently need tested and the staff need tested. And I'm not sure we have the rapid data yet from those settings that we need. And as far as I'm aware, we don't have data and we've not yet got the capacity in primary care and out-of-hours settings. So if we're going to have a mass testing program, which I think we need to do for test, trace, isolate, we need real-time data from those settings so we can figure out what's going on. And my understanding in Wales, actually, they're a little bit of a step ahead of us in terms of some of those real-time data issues. And then also for the community, we need symptomatology. So if we're going to roll out, as Sir Harry said, more widespread testing, the other way we can help alleviate the pressure on the system is for people to report their own symptoms. So you know there is the C19 symptoms app, which King's College London developed, and of course the Scottish Government has endorsed, but I haven't heard us talking about that very much. And as far as I'm aware, there are not as many people in Scotland using that as there are, again, in Wales, for example, where the public communication on that has been perhaps a little bit clearer. So I know there's concerns about apps, and I know we'll probably come on to the app that would help us with contact tracing, etc., and the Bluetooth technology. But those symptoms issues, I think we really need to pay attention to as well. I'm not sure I've directly answered all of your question, but I hope that was helpful.
No, that was exceptionally helpful. Thank you. Just one brief final question, and on this point of data. Do we have enough data yet to know what the role of health and care staff is in the transmission of the virus? A number of suggestions, international studies suggesting that the significant numbers of asymptomatic or mildly symptomatic staff could have a significant role in the transmission of the virus in health and care settings. Do we have data on that here? And if we don't, how do we go about gathering that?
So we don't have good data on that at the moment. I think you're absolutely right. So there's a big debate in the scientific literature about what proportion of people who come into contact with SARS-CoV-2 develop symptoms, and what proportion of them, in terms of becoming symptomatic, then become unwell, etc. It's going to take some time until we have an accurate international picture of that. But it's absolutely clear that both health and social care staff coming into closer proximity with patients who are symptomatic, and remember, it's symptomatic patients who are more likely to spread the virus either in the day or two before symptoms develop or when they are symptomatic. That's a crucial time period, is why PPE is so important. And then, of course, health and social care staff are going back out into the community. So I can't give you an accurate number there, but we're developing a better understanding of this through time, and it's absolutely crucial that testing is available for all of those staff and for patients as a first pillar in how we respond, and that they're adequately protected through PPE.
Thank you.
Thank you, Ross. Annabel Ewing, please, and after that it'll be Adam Tompkins. Annabel.
Thank you, convener, and I think, I'm not sure if it's still morning, to Professor Bald. To go back to the really important issue of the cancer screening programmes, particularly, for example, bowel, cervical cancer screening programmes, which are paused. And I note that Professor Bald stated that she was optimistic that actually folk would be ready to resume those. I just wondered then, what is the gap? What are the key practical difficulties of going from the pause to resuming? And picking up on the testing point, excuse my ignorance, but in that regard, would it be the case that those conducting analysis of those tests would be also dealing with tests for analysis of COVID-19?
Those are really good points, Annabel. And so I think there's a couple of issues there in response to how do we get screening up and running again, and what are the kind of systems issues in terms of the practicalities of that. So I think colleagues across the cancer pathway and also from cancer charities, including CRUK, would say there is a willingness, but of course what we're going to be faced with is a backlog. So there's really practical things to think about. How do we get the patients back into the system who've missed a screening opportunity? How do you communicate with them? And then how do we stagger access to those services when they're up and running again? That's absolutely the first thing. And we need safety netting for the people who've missed an appointment, and there might be consequences as a result. But the second point you've raised is really important in terms of diagnostic staff. So we were already under-resourced in that area in Scotland, and indeed across the UK. I think I have some figures here, actually. I think that, I'm not sure if I can find, around 1 in 10 diagnostic posts were unfilled across the US NHS. So that's clearly going to be an issue. But you're right, some staff, very skilled staff actually, have been diverted in relation to COVID testing. And the cancer community, including CRUK scientists, have embraced that. So there's a system shift. I wasn't suggesting that we are ready to go or my colleagues are ready to go. I was just trying to suggest there's a real willingness, and I think they very much welcome the support of the Parliament and the Scottish Government, and indeed, crucially, NHS boards, to think carefully about how we restart that when the time is right.
Okay, well, thank you for that, and certainly it's a point that I'm sure many of us would wish to pursue with our local NHS boards to see what the planning is for that, because it's very important. Another very important part of our daily life that we're not actually participating in at the moment. My other question, if I may, convener, is going back to the key issue of messaging. And, I take the point about one message and all the rest of it, and not to really to get into that sort of debate today. But I would just say that for me, I think the key thing is the message is clear. Now, if we have any change in the current lockdown restrictions, per se, in and of itself, the messaging will become a bit more nuanced because it will have to deal with more variables. But the key thing to me is it's clear. And picking up a point made, I think, by Monica Lennon in the first session, this issue of what are the symptoms. Now, as far as I understand it, the WHO actually extended the list of symptoms. And I think it would be, and I get why when you start off this and you deal with the immediacy of the urgency of the pandemic, you start somewhere. But presumably it would be important as we roll out the testing and tracing, that we actually get a handle on all these other symptoms that are presented with people who have been tested positive for COVID-19.
Yeah, and I think the symptomatology is definitely evolving. And again, the scientific community can assist with that, not just the WHO. So as we move forward, Monica, you're absolutely spot on. The messaging has to be more nuanced, but I think the resources have to be more nuanced. So in the work that's been done on international comparisons that my colleagues in the Usher Institute are doing, and of course, SPICE, the Parliament Information Centre, has been looking at the international evidence. There are some really useful sort of pathways, infographics, quite complex, but easily displayed resources that countries have used. I'm sorry I keep going back to Canada, it's just because that's the country I'm most in contact with. But if you look at what the government of Ontario, for example, has done, and actually there's some good resources in Ireland as well, in terms of releasing lockdown in stages, which I imagine is what we will see in Scotland, the rationale for why, for example, it's okay for businesses that operate outdoors again, or why we're allowing smaller groups of households to meet together. The rationale for that needs to be clear. We then need to have clear information about when that's happening, so a phased approach, and also relating back to Monica's question about who is affected or not affected by that new recommendation. So those are nuanced messages. They are not going to be able to be communicated simply to the public in one daily briefing. They're going to require Public Health Scotland or other agencies to support us to be able to convey to the public why something is happening. As I say, other countries are doing that in quite a sophisticated way. So let's learn from what they've done and try and do some of that.
Okay, thank you.
Thank you very much. Adam Tompkins, please, and then after Adam, it'll be Stuart Stevenson.
Thank you, Convener. Good afternoon. And thank you very much for the clarity of your evidence so far. Can I just pick up one aspect of what you talked about right at the beginning of your remarks about the importance of the clarity of communications? One of the prime reasons why the lockdown was imposed in the first place was to prevent the NHS from being overwhelmed. I think is it safe to say, would you agree with the remark that it's safe to say that we're a very long way away from the NHS being overwhelmed? Thank goodness. We've got, for example, at the moment, 89 patients in intensive care in Scotland and the capacity of 585 intensive care units. We've got at the moment overall in Scotland 1,632 patients hospitalised with COVID and capacity of more than 4,000. So with intensive care operating at 15% and hospital capacity operating at 38%, isn't it the case that we've now reached a point where the health risks associated with lockdown are outweighing the benefits that lockdown is bringing? Or am I misunderstanding the science and the statistics here?
So I think I'll give a slightly different response to the one Sir Harry gave. Is that I tend to agree with you from the data I've seen that the UK's really been successful in not overwhelming the NHS. And actually, because we have had the data that we have had that is good, has been able to show us what's happening in hospitals, in ICUs, with mortality, etc., even if we haven't known exactly the number of cases. But there are risks. So, I mean, my personal feeling, and we haven't talked much about some of the other economic impacts that will cause mortality, as in unemployment and all things that come with that, but they are highly relevant and they're only longer term. So my sincere hope is that we do start to release some of these measures soon and that we can get the NHS back up and running again. However, if you want to be confident about next steps, you need to be confident about longer term trends. And I do have sympathy for both the UK and Scottish governments in relation to just wanting a few more weeks' data to be absolutely confident that the numbers really are going down. And then also to be clear about the science about what the steps would be for releasing some bits of the population or allowing us to do more things. But crucially, as I said at the beginning, what I'm worried about, when we talked about the RO number, and again, I have other colleagues who are far more expert on this than me, I would emphasize, I don't quite understand how we actually know what the RO number is. accurately, because we simply do not have those rapid data sources that I described earlier to be able to be very confident. So we need more capacity and more rapid data to track what happens next. So I understand the caution. And I think that if we could be a little bit more confident about the numbers, we would be able to move more quickly. But I also think that soon we could do some things. I think it's very important for the public that we do allow people, for example, to go out more often. I hope we'll be given guidance about being able, some of us or most of us, to have contact with a small number of others not in our households. And crucially, that we're given clear guidance on some sectors of the economy with appropriate social distancing, which will allow to go back up again. And I think we should try and do that soon because of these other adverse health consequences, not just on the NHS. That in order for us to track what happens after we do that, the data is going to be so crucial, because only then will we recognise whether we are at risk again or at risk of moving back up in terms of the case numbers. So that's a very kind of academic answer in terms of we need data, we need surveillance, but that's just it's a personal view, but it's backed up by what I see and what I read and what my colleagues mentioned.
No, that's very helpful, thank you. And there's absolutely nothing wrong with academic answers, not in my view anyway. But you've anticipated in that answer, Professor Ball, a little bit about what I was going to ask in my second question, which is, given that we have to subject all of this to a whole range of caveats, and you've already done that, where would you start if it was your decision? And you've intimated that you would start by increasing the amount of outside exercise that we're not merely permitted but encouraged to take, and also that you would start by increasing the number of people that we can associate with, not merely in our households. Those are the two first steps that if and when the headroom is there that enables us to take any steps at all to ease the lockdown restrictions, that's where you would start. If I've understood that right, just could you give a couple of reasons as to why you would start there rather than elsewhere?
Sure, and I'll add to that in terms of other things, I think. So the first thing is, well, why outdoors? Well, I think all of the members understand that in terms of transmission of the virus, we're less at risk at outdoors, particularly if we maintain some distance from other people. Transmission is just not the same. There's very good scientific reasons for that. I also support what Sir Harry was saying earlier about face coverings when we are indoors in public transport or retail settings. We just need to do it, even though the evidence isn't strong. There's enough evidence to make that practical step. So that's why I suggest outdoors. In terms of contact with others, I think that the mental health aspects, the isolation, etc., are really, really building up. I mean, in terms of young people, as Sir Harry said, with no exams and complete uncertainty, allowing them to go outside and see their friends but maintain contact with them or one other household, I think is going to be something that will be important, not just because of the science, but because that's how we operate as a society, and that's a practical step outdoors. I would also say, though, that we need to have a public debate about businesses that would be allowed to reopen, or the government needs to seriously consider how we support businesses that can implement, for example, in open plan settings, perspex screening instead of just the arrangements of desks that we have at the moment, partial return in terms of staff coming in one day and another group of staff the next day to separate people out. We really need to start doing some of that in the coming weeks, the way that other countries are. And then I do just want to mention schools, if that's all right. I know that what I understand, and there is again a debate about the role that children play both in the transmission of the virus, even though they're at lower risk. And other countries are taking really quite fundamentally different decisions around schooling. Ireland, as you know, has decided they're not going to open again. Denmark has prioritised schools, as have some of the other Nordic countries, etc. I think I understand a paper has been submitted in terms of the advisory group for COVID-19 on school. And I know the term is ending soon, but I think it would be plausible to consider whether some pupils couldn't go back, even for a very short time, before the end of term. And I know teachers and others will be concerned about this, so that the education is not totally disrupted. So that for particularly pupils at crucial year groups, and we're talking here about our transition years and also our pupils who are facing national assessments, So that if they're going into a long summer period with basically, let's face it, nothing, it's difficult for the schools to provide resources through the summer, and crucially, it's really difficult for the pupils to maintain any motivation to look at that stuff, as all parents will know. That brief contact, just to set them up and support them for those months until they come back in September, I think we should actively consider, and I don't think there are strong scientific reasons why we couldn't do that for a very short period, because in a way it's a natural experiment. If we allow some groups to return in a safe way, we will then be able to see, if we have the data, what the outcomes of that are. I'm not suggesting we take risks. I'm just raising it as an issue at this point.
Thank you, and thank you to Adam Tompkins. Stuart Stevenson, please, and after Stuart it'll be Beatrice Wishart.
Professor, just an observation about schools in Denmark, where my nephew is a deputy headmaster at a school, Copenhagen. They've got all grade schools, so when they take back primary school kids, they can spread them around a large number of classrooms and maintain social distancing. And I think it just illustrates how the detail sometimes reveals things about different policies in different countries. However, that's neither here nor there. And by the way, I'm 73 and I check in with the C19 app every day. One of 3 million people across the UK who are doing so. I want to raise two things. The first of which is just kind of a very high level general thing, addressing you as a public health professor. Whether you think we've given enough priority in the long run to the whole issue of public health. My father, who was a GP, didn't require to study to pass an exam in public health when he graduated. He had to go on the course and sign in, but he didn't have to do an exam. Have we got a long-term failure to deal with public health in a properly significant way over the long term, Professor?
Absolutely. I mean, I've been working in this for over 20 years now, and I also teach medical students. And I think that prevention generally, and public health in particular, is still hugely undervalued, both in how we approach clinical training. There's really still very little public health content, not to point a finger at any institution, it's just a national problem. And then in terms of our NHS and public health infrastructure, it has been under-resourced for quite some time. And of course, things have been worse in other parts of the UK because of reorganisation and taking public health out of the NHS, etc., but not to dwell on that. So there have been benefits in Scotland of not going down that route. But I think the reality is, and again, from an academic perspective, it's much more enticing to put your money on the next big pharmaceutical development or your next treatment option, particularly when you have patients who urgently are quite rightly calling for technology and for medicine and for development. That's where it's our instinct to put our investment. And the cheaper, more basic approaches, which are often about public health, which are about long-term benefits and protecting our population, are not quite as quick and not quite as appealing. So I think, unfortunately now in Scotland, we all find ourselves in a position where we're all learning about public health because we have to, and we're expanding our knowledge of what our basic fundamental principles of public health involve. So I think this is an opportunity for us to look ahead and ask, not just in general practice training, but in all aspects of clinical training and indeed in other areas that feed into public health, have we got the system that we need? And how do we improve it so that when we face challenges in the future, which we will, not just about communicable, but also non-communicable that are caused by preventable risk factors, how can we be in a better position? Thank you very much for the question.
The second question that I have relates to my question to Harry Burns on R0. And one of the things he said, which I suppose I knew, but he confirmed, is that it's running a week to 10 days behind the on-the-ground reality. You yourself talked about the need for other data that are going to be able to inform us. quick data that more readily reflects what's going on. Particularly important, it strikes me, if we move into an adverse movement where we can't wait a week or 10 days to know what's happening. What particular kinds of data should we be collecting that will help us to be quick on our feet, particularly if, as we some of the current restrictions and experience an adverse move in mortality and infection? What should we collect?
Okay, so in terms of just going back to this real-time data infrastructure, I do think we need to think about all the different pillars of that. Sorry, I'm using the word pillars, but let's say segmenting it into sections. So just on technology, Stuart, you rightly pointed to the COVID-19 COVID symptoms tracker. Let's communicate more clearly about that. That's going to be hugely valuable data. Secondly, the NHS contact tracing Bluetooth technology app that's being developed at UK level. I know that will be actively discussed as to whether that's the right one for us or not, but we need some digital technology that will help us in the way it has in other countries, but that's a small part of the picture. I wouldn't put all our money on that solving our problems. And then just to go back to the points I made earlier, how can we get rapid data, real-time data back on number of cases in different settings? So the high-risk settings, also primary care and out of hours settings, as I said, other community settings where that might be possible. We've not raised prisons, etc. That's obviously crucial as well. So these are all components of a system where I think if we can have that feeding in, and I think it's brilliant, we've got Public Health Scotland now and the Health Protection Directorate, etc., working together in boards. But let's try and increase that capacity so that we can be more confident about that RO number going forward. Because unfortunately, as you know, we're going to be tracking this until we have better treatments and a vaccine for many, many months to come. So even if it takes a bit of time to get this right, this is the time to work on it, I think.
Okay, thank you very much, Stuart. Next, Beatrice Wishart, please.
Thank you, Convener, and good afternoon, Professor Bald. My question rather follows on a little bit from Stuart's question there. It's about the apps that could be used for tracking, tracing and isolating, and it looks like we could have two apps, one from the Scottish Government and one from the UK Government. So I'd be grateful on your thoughts about the importance of clarity and consistency of messaging in relation to that technology that's set out to become part of what comes next, and how this should be approached if the intention is of both governments to increase and maximise uptake.
So a number of things there. I think there, in terms of whether we go with a UK approach for the contact tracing app. So this is the app, obviously, that would identify if somebody has symptoms, give them advice to get tested, and then be able to alert others who've been in close contact with them. And that's the kind of app that's been developed. In Singapore was the first country. Australia, for example, has recently developed one. Other countries have been either good or not so good in terms of their use of that technology, but I think it has a role to play. In terms of how it's taken forward, I'm no expert in those areas, but it will be important. But in terms of how we encourage people to use it, that is an area where I feel more confident commenting. And there is some good research on this now. So we have higher levels of concern in the UK about privacy and about data protection than some other countries do when you look at the data that's been collected in international studies. So we need to basically get the governance right, get the governance of the technology right, so people are absolutely clear what they're signing up to, absolutely clear how their data will be used, very clear about how long it will be stored for and when it will be removed. And then we have clear public messaging, including potentially mass media, to try and encourage people to use it. Because I think as part of a systems approach, as I discussed earlier, there definitely is a place for this digital technology. We just need to recognize that unless enough people who have the type of phones, because let's face it, not everybody does, and we're still going to need the old-fashioned workforce of contact tracers within that system. So that's people phoning people up, basically. Unless enough people download it, it doesn't work very well, as we heard earlier in the session.
Thank you. Thank you for that. And my second question, it kind of goes back to the cancer diagnosis and the number of people who with other health conditions who aren't attending clinicians at the moment. So if social distancing is going to be with us for quite some time until we have a vaccine, and some of the reluctance that there is to go to the GP or the hospital still lingers, what can be done to make sure that health concerns are being picked up in the interim?
So I think there's a couple of things there. I think we need to be much clearer with our messaging that people should access all different types of healthcare services if they have a new symptom, bleeding, chest pain, or indeed, let's go back to the basics, reassuring parents about immunising their children, which of course we've had some discussion of recently in Scotland and elsewhere. We need to reassure the public that they're going into an environment that's safe, where there is adequate testing, there's adequate PPE where that's required, etc., and that they shouldn't withhold those concerns. So I think the communication around that is crucial. And then secondly, as I think we've already discussed, Beatrice, just getting the system ready to be able to receive patients. So I'm not sure I'm giving you a different response from the one I gave before, but I think those are some of the things we need to do, and colleagues and boards and elsewhere in the system, I'm sure, can advise in more detail on that.
Thank you. I think it's reinforcing what is required. Thank you.
Thank you, Beatrice. Last on my list is Shona Robeson. Willie Coffey's also indicated to me he wants to come back in with a question if we have time after Shona, but I'll go to Shona first, please.
Thank you. I wanted to go back to messaging, if that's okay, Professor Bald. Adam Tompkins raised an issue about the NHS not having been overwhelmed, which is obviously a good thing. But do you not agree we have to be very cautious about equating the fact that we haven't used all the ICU bed capacity, or indeed bed capacity generally, with that being sort of headroom for being able to ease the lockdown? Because my understanding is that, you know, we need to see intensive care as the sort of tip of the iceberg, and if we saw beds filling up in intensive care, that would signal that underneath that we have huge community infection, obviously a rise in deaths in the community. And also it would be good to get your take on some of the emerging evidence of people who recover may well be living with long-term conditions of impact on their heart, renal problems. So I think it's just to make sure we've got the messaging that, we don't have that headroom of just filling up intensive care just because the NHS hasn't been overwhelmed. It'd be helpful to hear your thoughts on that.
Yeah, absolutely. And I certainly do not for one moment want to give the impression that I think we should be releasing lockdown and just get on with it and see what happens, because that is absolutely not the right thing to do. I think the earlier discussion has been very helpfully trying to balance some of the adverse consequences of lockdown with the real and very immediate threat we face from the virus. And you're absolutely right, Shona, this is a very serious virus. So Harry mapped it out in much more detail than I need to now. And the people who come into contact with SARS-CoV-2 and develop COVID-19, for some of them, it has very adverse consequences. And what I was really pleased to see in the Scottish Government's principles document was a recognition, unlike earlier in the debate in the UK, that we're not heading for some kind of herd immunity, that the priority is to make sure that nobody will develop COVID-19 if it's avoidable. So you're absolutely right. The priority is to protect the population from becoming unwell as a result of coming into contact with the virus. So I think it's right that we don't just rush full steam ahead. We recognize that we need to take baby steps, and we need to crucially track where we are after each release that we offer to the population, in terms of opening things up very gradually, so that we don't get to that level where we will see more ICU beds needed and case numbers going up. In terms of international learning on this, so in terms of the recovery point, you're absolutely right. In the scientific literature, we are seeing new papers, and there was one out this week which you probably are referring to, in terms of some of the respiratory conditions, long-term health outcomes that might arise for people as a result of having had COVID-19. We don't understand those fully at the moment, but it wouldn't be unusual, because we've seen from certain types of influenza, from other strains, we've seen the kinds of long-term consequences that some groups suffer. So we shouldn't just assume that somebody who has a short-term positive outcome, as in they recover from COVID-19, won't, for some groups, have long-term consequences. So that's a really important point to raise. In terms of the international comparisons, the other point I just want to emphasize is the way many countries are approaching this is quite clear differentiation of the gaps between each release of the current measures. So there are some countries that have done it quite quickly. Whether that's a good idea, again, we'll only see in the fullness of time. Some of those countries had very low numbers of cases to start off with. Other countries are, having several weeks between each stage in their release strategy. And that's something I think we should actively consider as well, because it allows us to track, as you rightly point out, not only health service capacity, but also if we've got the data on the case numbers, we can take action if we see cause for concern.
Thank you, that's really helpful. And just finally on that point, clearly data is going to be hugely important, as you've talked about throughout this session, if we're going to make sure that if we take a measure, it shows that actually we need to retreat from that because of a rise in infections. You touched around real-time data being quite good in hospital settings, but I think you maybe had something more to say about some concerns about community settings. So, do we need to do more to make sure we get real-time data, quicker data from care home and primary care settings? What can we do about that?
Yeah, absolutely. So we need the infrastructure for the return of the data from those settings to be more rapid. I don't underestimate the systems challenges that are involved in this, even at a basic level in terms of IT, but also then the receipt of the data, how quickly it can be processed and how quickly it can be synthesized, because what you need is multiple data sources feeding into an overall picture that would inform the Parliament and the government and our other key agencies. So I think I was just trying to set out what I would see as the key components of how we build that real-time data. I think there are others who will be able to advise on, for example, in general practice, in out-of-hours settings, what are the blockages in the system to get that working at the level we wish it to. In terms of the community, I think what we're primarily looking at there will be the test, trace, isolate approach, because you can't, we're not routinely receiving data from our population other than by using technology or by using that test, trace, isolate. So I think, as I've said before, getting that contact tracing workforce up and running and into place across the country, the people who need to be trained, you may be more up to speed with the details of how that's developing than I am. But, that's old-fashioned public health. As you know, Shona, many countries put that in place early on and didn't stop having it, or they built it up in the period, even if they'd abandoned day-to-day contact tracing. They knew they'd need it again when they came out of higher case numbers. So I think that human resource aspect, we shouldn't underestimate the importance of that alongside the systems issues we need to address on the data.
Okay.
Thank you very much, Shona. I think Willie Coffey was keen to come back in with a different question.
Thanks very much, Convener. Professor Bald, many of our constituents are asking us, where are we in terms of getting a vaccine for this virus? Have you any perspective in where we might be? We hear about clinical trials going on here and there. So what's your view about where we might be in terms of getting a vaccine for the virus?
So we had an excellent session from the director of the International Vaccine Institute in South Korea. The webinar is available on the Usher website if colleagues want to listen again, just 10 days ago. So from my understanding, there are about 75 different approaches in trial at the moment, whether they be in animal models, cell line studies, or indeed, as you now know, some trials in humans, what we call phase 1 to phase 2. So that's brilliant. The scientific community, with support from funders, has responded incredibly quickly. And here in Scotland, of course, the CSO is acting with NIHR and UKRI to support rapid science, and I really welcome that. But I think the estimates of how far away we are from having a viable vaccine do vary a lot. Oxford colleagues seem quite confident that if they can continue to move ahead in the next few months, we may be looking at less than a year, for example, and others are more pessimistic about the time frame. So I don't have any more specific insight than that. But what I would emphasize is that we've never seen this speed, or certainly not in recent years, in terms of the global scientific community focusing their efforts on a particular issue. So I'm really optimistic that we can make progress there. And then how viable or how effective it is, that's the second question that we need to ask. And we'll see that through time. But I think a vaccine will be part of the picture, an important part of it. But of course, it's not everything we need to do. I think the treatments for patients who become very unwell with COVID-19 will be really important as well. And again, we are making rapid progress in terms of the studies that are underway to look at some alternatives there. So I think there's cause for optimism. We need basic public health, but we also need medical science to address this problem. So the two acting in harmony, I think, will, in the longer term, be very important for Scotland and the wider world.
Okay, thank you. Thanks, convener.
Thank you very much. Thank you very much, Willie. Thanks, Professor Bald. I don't see anybody else wanted to come in with any more questions. So just before we wrap up, is there anything we haven't asked you about in the last hour or so that you're keen to tell us? Anything else you want to get off your chest while you're here?
I think the only other thing I would sort of emphasize, other than the international conversations which are ongoing and many people in Scotland are contributing to, because I would think we need to keep those going. And I think when we face this kind of crisis in the future, a global public health, a global effort will be what is required. So countries need to work together. The only other thing I would emphasize is in terms of, since you've given me the opportunity to contribute as an academic, is that, we have outstanding colleagues here in our universities and our research institutes in Scotland who can support parliamentarians and governments to make good decisions. And we just provide information and findings. Then, of course, you and your colleagues make the actual decisions. But I think there might be a wider group of researchers and others who would be keen to contribute to Scotland's effort in this space moving forward. So I guess I would just emphasize in your report and your notes in terms of this discussion, an open question about, are we using all the different types of expertise that we need? And as we move forward, our economist colleagues are thinking about welfare, infrastructure, transport. All of that expertise is going to be needed because it's really a whole system approach that's required to address this.
Okay, thank you very much. I think I spoke too soon, because I see Monica Lennon is keen to come back in for this other question. Monica.
Thank you, convener. I was waving, but I don't know if I was on the screen at that point. I think as we've been speaking today, there's been some updates on social media from the BBC and others that the Prime Minister is expected to make quite a significant announcement on easing lockdown. I think that will be on Sunday night. Now, that will apply to England. In terms of public health messaging, I just wondered if Linda could say, because that's going to be a very immediate challenge, how can we manage that in Scotland if the message is in fact going to be different in the coming days and in the coming weeks? And how concerned should we be that when people turn on the news at night and hear the Prime Minister say something, they'll assume it applies to Scotland when the picture in Scotland could be quite different? How can we manage that in practical terms?
Absolutely, and of course this has been an issue in other countries like Australia, where they have a federal system and states have taken different approaches. So Scotland is not unique in the position that it finds itself in, just to emphasise that. I think that's a challenge. I would be surprised if the Prime Minister did anything too reckless at this point, because I think that's really not in the interests of the health of the population, but we'll see. I think the importance is clear communication and rapid communication. So if we're going to take a different path in Scotland, then our leaders need to be very clear about the rationale for why it is a different decision and what evidence underpins that rationale. So there really needs to be evidence that's made clear to the public about why we're not ready to do X, either because the risks are too significant and therefore what are the risks, or because we are in a different situation and our data tells us something different. That needs to be communicated. So that's the key, is to try and underpin any decision with that kind of rationale, and then also be ready to answer the public's questions, because I'm sure you found yourself, Monica, and everybody has, when we issued our simple messaging at the beginning of this, and I was, for example, contributing to question and answer sessions in the media, there were so many questions from the public and that I, as a researcher, didn't know the answer to, because for everybody, they interpret the messaging differently and their circumstances are different. So I think if we do take a different decision, we need to be clear about the evidence, the rationale for Scotland, but also be ready to answer the public's questions, as I think we are in Scotland, about how that difference applies to them and how they should interpret it and move forward.
Thank you.
Okay. Thank you very much. Thanks, Monica. I think we have to draw to a close there because our time is out. So can I just thank you again, Professor Bold, for your evidence. I think it's been very helpful to the committee, and I'm sure we might well be speaking to you again at some point in the future. And with that, I will close this session of the committee. Thank you all.